My name is Virginia. I'm known to some of you in the room, but not all of you. I have a day job, which is as the Global Partnerships Executive for the Fred Hollows Foundation. I'm based here in the UK. But the job that excites me the most, can't say that to my Fred Hollows Foundation colleagues, but excites me the most about the work that I'm doing across this sector is the engagement with the work on the elimination of blinding trachoma. The International Coalition for Trachoma Control it occupies a substantive amount of everybody's working time. We're all very committed to the elimination of trachoma as a public health problem. And I'm going to share a little bit about the disease, about what we're doing, and about what excites me about that in our time together now. I won't assume that all of you know much about trachoma, but I will give you a little bit of an overview. It is the world's leading cause of infectious blindness. It affects approximately 232 million people who live in endemic areas, and almost 1.2 million of those people have irreversible blindness as a result of trachoma. So trachoma is caused by an infectious bacteria, Chlamydia trachomatis, and it's passed through contact from eye discharge between people from infected persons via their hands, fingers, towels, sheets, anything that's coming in contact with eye-seeking flies. And it particularly thrives in areas where there's poor sanitation and limited access to water for personal hygiene. Where you've got cases of repeated infection, you can see a scarring of the inside of the eyelid, where the eyelashes turn inwards and repeatedly scratch the cornea of the eye. So every time you're blinking with this disease, you're in excruciating pain. If that active infection and cycle of infection isn't broken, that can turn to blindness for those affected people. We are very fortunate in the trachoma space to have a very well-considered WHO-endorsed treatment strategy, which looks at the surgical, antibiotic, facial cleanliness and environmental improvement components of the prevention and treatment cycle. I'm excited to say, and I think we don't do enough work on this in our space, to be celebrating some aspects of the work that we talk about. In 2014, our community was very excited to recognise that a population of 12.6 million people no longer required the treatment cycle for the antibiotic component of the active infection for trachoma. So those districts had impact assessments which illustrated that the prevalence of the disease had fallen below 5%, or the threshold for elimination, as a public health problem, just to confirm the definitions we were talking about this morning. A little bit about ictc, just a plug for the group. I'm showing you a slide of many of the member organisations in our group. It's a multi-stakeholder community of more than 44 members and observers, largely non-government development organisations, representatives from donor communities, academic institutions and training organisations, and of course the private sector. We come together to support the Alliance for the Global Elimination of Blinding Trachoma by the year 2020, and we largely advocate for the elimination of trachoma as a public health problem, but including through the very active implementation of the SAFE strategy by many of our members in support of the national programs in endemic countries. We're currently focused on the scale-up needed to reach elimination. You can imagine that 5 years out from that target, we are very busy looking at moving from a typically business as usual approach to a significant scale-up opportunity. We're focusing on capacity, new funding opportunities, and the implementation of initiatives which strengthen public health systems. For anybody who's interested, we have also just adopted our new strategic framework for that period, and on any of the slides that follow, you'll see our web address at the bottom. So any of the resources that I talk about, you can get through that web address. What I want to do today, though, in talking about closing the gap, and I've been invited to speak on that topic, is look at two specific examples which I think really illustrate how our sector is scaling up to close that gap for blinding trachoma. The first is a super exciting initiative, and I'm sure many people in this room are familiar with it. It's the Global Trachoma Mapping Project. And if I think about what we know or didn't know before this initiative started, I'll guide you through it. In 2011, as a trachoma community, we couldn't confirm whether trachoma was actually a public health problem in nearly 1,500 districts in the world where it was suspected to be endemic. So this particular initiative was catalysed by some funding provided by the Department for International Development here in the UK. And the aim of the Global Trachoma Mapping Project is to complete the baseline mapping for trachoma by December 2015. That's in a few months. That initiative received additional funding from many other partners, including USAID. And through that initiative, you can see that to date, it's examined more than 2.2 million people in over 1,400 health districts, involving a significant number of partners coming together, working closely with governments on their national trachoma program priorities. As a result of this initiative, we've got a significant amount of data that is ready to be analysed and able to inform program planning in 23 countries, which is impacting a population of 212 million people. This body of work has generated many things, and I'll talk about the lessons in just a moment, but it's specifically informed 2 ictc partnership initiatives, one with the Queen Elizabeth Diamond Jubilee Trust Trachoma Initiative in Africa, and the other, the DFID SAFE program, also in Africa. And that has brought together a composite of funding around £80 million in 9 countries, and implementing activities in hundreds and hundreds of districts in those countries. The work also obviously has been used for other scale-up grants that are made directly to ictc members. If you're interested in the background to this particular initiative, there is much more information in the paper that's outlined in this reference on the slide. What I want to do is give you an example here of how that data and information arising from the Global Trachoma Mapping Project has been used, not only to guide scale-up in Ethiopia, the country with the highest burden of trachoma in the world, but also to impact the collaborative efforts of funders and policymakers in this area. And I offer thanks to colleagues from Ethiopia who demonstrated this scale-up for trachoma at a presentation at the NNN last week. I've picked 2 of the slides, and unfortunately they're not dynamic. It came from a series which built the excitement to a crescendo pitch. So you'll just have to imagine that we're pitching in that way. So in Ethiopia, when I first visited maybe 4 years ago, we were looking at a trachoma program that was largely in play, well, significantly in play in one area of the country, the region called Amhara in the northwest part of the country. And more than 70 million people were living in trachoma endemic areas. So there's about 90, 95, depending on which data source you refer to, million people in Ethiopia. So that's a significant burden of the population. Through the coordinated efforts of many stakeholders within the Global Alliance in the last 3 years, and using the mapping, the data arising from the GTMP, you can see that this is the current situation. 86% of those endemic districts are now covered for programming and funding for S and A components of the SAFE strategy we were talking about earlier. And 70% of the endemic districts are covered with full SAFE based on a collaborative effort with a national campaign in Ethiopia called One Wash, which brings together a number of external stakeholders with a significant funding base behind them to tackle WASH initiatives throughout the country. So this sort of scale-up is reflective of the types of initiatives that are underway in many countries. Not quite to that scale, but the intent is that we program and seek partnerships for comprehensive SAFE implementation in all endemic countries to assist national programs achieve their elimination objectives. So for Ethiopia, fantastic news, crescendo of applause. You'll see there are also some gaps remaining. So we've still got some work to do for Ethiopia, and it doesn't mean by any stretch that the trachoma burden for Ethiopia is in any way solved. This illustrates that we now have a platform to be operating at scale for safe implementation. So I think there's a lot of things that are encouraging and to celebrate about this particular example. But what I wanted to focus on for this session is not so much the examples, but just to familiarise them so that you can see where I'm going with this, is really to look at what the learnings are for our community, and not just the International Coalition for Trachoma Control, but the broader trachoma community. There are some key things we've learnt about moving to scale up, and I guess that's really what we're doing in the last couple of years, and definitely for the next 5 years. We're talking about operating at scale, and significantly, I've said it before, this is not a sort of business as usual approach. We're all operating in different ways and significantly through partnerships. So what this slide illustrates are just some of the key learnings that are emerging from our programming and partnerships. The aim, of course, of any good program of work is to try to identify and then apply as quickly as possible the learnings that we derive from these activities and apply them at a field practice level so that we can be adjusting and recalibrating efforts and keep the momentum focused on that elimination objective. And things like evaluations and operational research and the like really play an important role in generating that field-ready information, but they also significantly inform changes to policy and practice. And what's true for the trachoma space is that a lot of the substantive norms in our operating environment are subject to change at the moment. It's a very dynamic space, and we're looking at what the implications of those changes are for the next 5 years. I think some of the things that Guillaume was talking about for polio just now, in terms of the use of mobile data collection, and that David referred to earlier with partnerships and the importance of policy and advocacy, are certainly learnings that we have seen through this scale-up activities. But the key four, I guess I would really refer to, planning at scale is something that is critically different to just your everyday planning as an organisation, and it involves working very closely with other stakeholders in an open and transparent and pretty honest way about what the challenges are and how we'd overcome them. The things that have really driven us forward in our sector are the standardisation around our approaches to planning, training, engagement and implementation of preferred practices and WHO's global guidance. What that has meant is that the methodologies we're using across programs are highly transferable, and there is a lot of inter-country cooperation with a lot of trainers and planners moving between countries to support scale-up efforts in other environments, and that's been a particularly successful element to the program. I won't necessarily go through all of them because I think it's fairly obvious to say that collaboration is a key to success, and what we do together helps people to build confidence in their own activities on the ground. What I will focus on though is what we're looking at for the next steps. So what are we focusing on for the next 6 to 12 months? Within our sector, the ictc, the coalition, we're looking at an activity to more closely identify the cost of implementing SAFE at scale and including that all-important surveillance component. It's an iterative costing, but what we knew in 2011, before this significant scale-up, and before we had data for sort of almost half the health districts in the world, what we knew about costing then is that we'd anticipated it would cost $430 million to address the confirmed burden of the disease, and that figure could increase to $750 million if only 50% of those areas suspected as being endemic actually turned out to be endemic. So you can see that's a big costing range to mobilise funds for elimination. So we've got some information coming out in the early new year looking at a much more nuanced series of costings based on the outcomes of the Global Trachoma Mapping Project. We're also engaged in a body of work generated by the NNN WASH Working Group, and that's looking at a series of WASH and NTD indicators to try to identify a handful of universal indicators to apply across the NTD sector. And we all know what gets measured gets done, so I know that there's a lot of people eagerly awaiting that. If you are particularly interested in taking part in the Delphi study, which is guiding this body of work, please come and see me through the breaks or send me an email and I'll connect you up with the study, the folks guiding the study. We're significantly looking at the scale up and rollout of the new F&E tools that have been produced by the Coalition. And also, and I know that Dirk will be talking about this afternoon, but I'll give it a plug, the really excellent WHO WASH and NTDs strategy that's just been launched both at Stockholm World Water Week for the WASH sector and at the NNN meeting for our NTD community. So significant components around the WASH aspects of the SAFE strategy. We have a number of global consultations underway, really looking at the challenges at the end game, in that final mile. So what are we doing about trichiasis patient tracking as we start to really tackle that backlog of the surgical burden and we find the hard to reach patients? What are we doing about trachoma surveillance in that post-validation phase? Things that are critically going to affect the as a public health problem component of the agenda. What happens post-2020? As a coalition, we also have a progress report coming out looking at 2020 Insight. It's an update on a document we published in 2012. So we'll be looking at progress since then and what we anticipate as the key hurdles and challenges in the next 5 years to the elimination timetable. So what would I want you to take away from what we've been talking about? Today, as opposed to 5 years ago, we critically know where the disease exists, thanks in part and whole to the Global Trachoma Mapping Project. So that initiative mapped around 1,500 health districts in 3 years, and it had previously taken 12 years to map a similar number of health districts. So you can see that there's a tremendous momentum being built up around that initiative. We also know how to treat the disease, both in its active form and for the ongoing sustainability of the program through the F&E components, thanks to that SAFE strategy, and thanks in part to the field learnings of ictc members identified through a range of preferred practice materials. And again, as a plug, if you'd like any of them, the website address is at the bottom. We have a hugely committed group of stakeholders through the Global Alliance, which includes WHO, it includes representatives from the endemic countries and funding partners, pharmaceuticals, non-government organisations, academic and training institutions. We come together annually to meet and really look at what the key challenges are for the next period of implementation. We continue to generate evidence and field experience to identify where the ongoing challenges are and try to attract resources to fill the gaps around those challenges. So what I'd like to focus on just in this last few moments is really what I think we're here today to talk about, and that is that there are a number of challenges remaining for trachoma, but also I think for other disease group areas. So I would hope that we can tackle some of these in the discussions this afternoon to really inform the way that the Society might put together its policy platform and think about the 4 or 5 day meeting that's on next year. And I'll summarise them like this. There is a lot of cross-learning between the disease areas. For some of us, we remain so focused on what we're doing that we forget to look outside our own disease groups. There is a lot we can learn from, I don't really want to say the failed diseases, as they were referred to earlier. But the diseases that have gone before us and had the experience of trying to tackle either elimination or eradication. What can we learn from them? And for the trachoma sector, we've done a lot of work recently with the leprosy sector to learn from their experience. Really focusing on multi-sectoral engagement, and that's from the outset. One of the things that we all do, I think, is talk very effectively to each other, but we don't often talk very effectively to people in other codependent sectors. Obviously, we're very health focused. What are we doing with the education sector, the wash sector, the finance teams, the other sectors and health departments in countries where we work, to ensure that we are collectively coming together at the outset of our programming efforts and engaging them in their language, in something that they're passionate about, to achieve our common objectives. I guess that speaks a little to the next point, which is making sure that we reframe the narrative for those final few miles. We can't just do what we've always done, because it's been successful to a point. It has meant that we've been able to tackle the low-hanging fruit, maybe even the middle branches of the tree, but now we're really starting to get to those higher branches, the unreachable areas. So if we are to ensure that we leave no one behind, as the key tenet of the new Sustainable Development Goals, we really have to start talking about elimination of trachoma as a public health problem and not perceive it as a vertical health intervention. And I think this really speaks to what we do around the challenges for cross-border issues, where there's infection across borders, because obviously populations are highly transient. And I think we saw that in the two previous presentations this morning. What are we doing about communities who need treatment engagement in highly insecure areas? So some of those really critically challenging things that have been in the slightly too hard basket to date. For us, one of the really important things is absolutely looking at who the new generation of stakeholders are going to be. What are we going to do as a sector about developing, engaging and empowering new leaders in the NTD community? I don't just mean in endemic countries, I mean in countries like this. We've relied significantly on those senior statesmen and women who've led the sector in the past, and I think perhaps it was a reflection of mine this morning that as I was thinking about the 2030 development agenda and realising I would be 60 in the year 2030, that we really need a lot of young people with passion who have the technical expertise, but also the excitement and partnership approach, who are keen on advocacy outcomes, as David indicated earlier, to really drive the development and the sustainable development agenda forward for the NTD space. And I think critically for this group of stakeholders in the room or online is what we do about bringing hard science and research into the evidence-based and influencing space. One of the things that's most exciting for me about being in the UK, and you might have picked up from the accent, I'm an Australian, I've been here for 3 years, but this sector is, this country is a world leader in generating evidence and excellent research outcomes. We really need to make sure that those outcomes are being disseminated to practical field application and policy and advocacy opportunities. If we don't do that, we're missing significant opportunities to bring more stakeholders into the end game discussions. I would hope we would talk a little bit about all of those things this afternoon. I think on that note, probably just to say thank you very much for your time and for listening to me. I look forward to engaging in sessions throughout the day, and I thank the Royal Society for bringing together the group of stakeholders to have these discussions. It's really important and I'm looking forward to it. Cheers.